what a spectacular presentation, and I know there's going to be a lot of questions. So we have a microphone somewhere. We have a microphone there, and you can just please walk up to the microphone, or actually, if you could hand raise your hand if you want to have the microphone, and we'll get the microphone to you. If you don't want to use the microphone, you can ask a question, and we'll anonymously using this poll. So you text Methodist to 37607 to join, and then text your question. And that'll pop up on the screen so that we can, Paula Ferrari has a question.
Amazing presentation, blown away. I hope that these slides can be accessible and be distributed and circulate. We'll certainly do our best efforts to put them out because they are so informative and can really probably help save lives. So thank you so much for what you do for this cause. My question for you is, how long does the increased risk of heart episode, fatal, before women that had chest radiation? I had DCIS, ductal carcinoma in situ, 10 years ago, and I was exposed to 6 weeks of radiation. And I remember the hardest thing was I was asked to hold my breath for the longest time while they were irradiating the area because it was so close to my heart. And so after hearing what you said, all my bells started ringing. So how long does that increased risk factor linger after you've been exposed to that kind of treatment? Thank you.
So it is lifelong, the radiation, once you've been exposed to radiation. And in North America, the estimate is that for the right breast, you get around 1 gray of radiation, and you get 1 to 2 on the left breast. We don't know why we get more on the left breast, but guess what lies under your left breast is your heart. And so we know for every increased dose of radiation, something like 7% increased risk of heart disease. So it's so important for anyone, obviously, like I said, with breast cancer, to get screened and know their risk. But, the hardest thing for cardiologists is we don't often know how much radiation you got, and patients don't know. They just know they got radiation. So we can take the best guesstimates that we think in the United States and knowing that and say, okay, well, if you got radiation, that the risk is increased. And that's the kind of conversations to start. We shouldn't be segmenting our care. That's, I think, a lot of what happens, So when you get pregnant, it's probably you're under the care of a gynecologist. When you get breast cancer, you're under the care of an oncologist. It's the beauty of electronic health records. Hopefully all these things will combine, but sometimes it doesn't always happen like that. And so make sure, this is the thing, is that even being empowered to know that these are risk factors is to talk with your doctor. Say, I may have not mentioned this, but I got radiation, and I heard that increases my risk for heart disease, and what should we know? What should we do different about assessing my risk?
Right. We have a question from the audience up on the slides there. In one of your slides, you showed polycystic ovarian syndrome, increased risk for women. We always hear PCOS in relation to weight and infertility. Haven't heard it in relation to heart disease. Tell us, remind us again what polycystic ovarian syndrome is.
So I didn't even talk about it. I did have it in one of my slides. You're right, whoever wrote that question. And I apologize. I felt like I had too much information as it was on my slides, which is always the case. But polycystic ovarian syndrome is something often, you're right, it is identified often when women have fertility issues or sometimes painful periods. We know, though, that it's also strongly linked with diabetes or insulin resistance. And that whole idea of insulin resistance, central obesity, central weight gain, so, being apple-shaped, if you will, rather than pear-shaped, that may increase your risk for heart disease. It certainly increases your risk for diabetes. So we know people with polycystic ovarian syndrome have an increased risk of diabetes, but they have this increased risk for metabolic syndrome, and there is an association with an increased risk of heart disease. So it is important. That's another thing to always bring up or to be asked, and that's why I think I had it on that slide, that is something that obviously can only happen in women, and that we need to be asking women, do you have any of that? And so a full sort of pregnancy history, because often a lot of people with PCOS might have fertility issues. So once you start talking about that, they might say that they had difficulty getting pregnant because of PCOS, but it's important for us to be asking that as a risk factor.
You have a question? Oh, there's many questions, yeah.
Good morning. Thank you so much for being here. As a healthcare consumer, I think one of the things that I experience is time with the physician. It's the time that we're actually in the office and conversing with the physician is often limited. How do we begin to broker those conversations? Because I can tell you nothing glazes over a physician's face when you say, I read on WebMD. I mean, they just immediately sort of dismiss some of that. So how do you begin to, ask for information about these risk factors and some of these coming in with some of these data based on some of these tests that you talked about? How do you begin to broker those conversations?
Well, I think the most important thing, because I totally agree that when you go to your primary care physician, of course, I've even heard from patients telling me that you can only bring up one issue or you can only have two things that you can talk about, otherwise they want a different appointment. So make sure that you're clear that the reason that you're there is for cardiac risk assessment, that I want to know about my heart disease risk. And believe me, when doctors, if you say, I want to know if I'm at risk for a heart attack, if that's all you remember, believe me, they're going to be like, that's going to put them on heightened alert. Why do you think you're having a heart attack? So they're going to start talking to you about it. If that's the reason for your appointment, I mean, if it's as you're walking out the door and you're like, oh, by the way, do you think I'm at risk for a heart attack? I don't know what they'll say. Time is limited, but I do think it is important to have these conversations, because certainly when you come in for your scheduled pap smear, right, they do it. When you go for your mammogram, they do it. When you're on, these are things that they should be doing every year. You should be having at least that discussion about cardiac risk assessment. If they're not doing it, if you don't know that 10-year risk and your lifetime risk, then you haven't had a cardiac risk assessment, in my opinion. And I always tell, often I start sometimes these talks where I have everybody stand up. I have them sit down if they didn't get their pap smear, their mammogram, everyone's still standing. When I say if they've had their heart assessed, half the room or more sits down because they haven't had their heart assessed. It's important for you to know that your heart is safe. We've said this, you've heard this from all three, the first three speakers, you're going to hear it probably for the rest of the day. It is the #1 killer of women. If you don't know if you're at risk, then we haven't done our job as physicians. So be very proactive. That's why, we create a lot of things. If you ever get time, go to something called cardiosmart.org. I'm the editor-in-chief of Cardiosmart, and we create stuff for you to actually come in with the questions. So you can download that if that helps you create the conversation. And that's a way to start, is just to know what questions to ask.
We have a math question for you. Why is the mortality rate higher in women, but they live longer? So maybe just clarify that for us.
So you're right, women do live longer. And actually, like I said, I hope I corrected myself that now the mortality rates overall are better for women than they are for men. But based on the last 2 years of statistics, less women are dying from heart disease than men. But the mortality rate is high. Of course, yes, women live longer. So like you heard this from the beginning, that they're going to die from something. Chances are they're going to die from heart disease or stroke. But what we should worry about a little bit more than that is not just what we die from, but what can we prevent? And then, as I said, the younger women is the group that I probably worry about the most, because that, in all other if you look at older women and older men, for example, we're seeing a reduction in mortality, which is fantastic. If we're looking at younger men, we're seeing a reduction in mortality. When we look at younger women, that's where we're not seeing the same leveling off. That is the group that we have to worry the most about, and that probably affects us because, losing a young woman from a heart attack is really hard, just like it is losing anyone. But younger people, they just have so much more to lose. And that's what we're seeing more in our hospitals, is more younger people having heart attacks, both men and women, at ages that you wouldn't believe. And then dying from it is a huge loss.
Hi. So I'm considered a young woman, I guess. I don't think so.
I'm jealous.
In the past, when I was in my 20s, I had some weird stuff going on with my heart. So they did the Holter monitor, the whole 9 yards, and they ruled out everything. Recently, I was having chest pains and stuff, so I went to see the doctor and did everything. They did a stress test, and that was it. And he's like, your heart is fine, and sent me on my way. And now I'm sitting here and I'm wondering, should he have done blood work? Should he have done this? Should he have done that? Because none of those things were done while I was there. How do I effectively get the same treatment a man would get if he said he was having chest pain?
Yeah, you're right. I always say that a man can walk into the emergency room with a stubbed toe and he'll get an EKG, and a woman, we have to beg for it. So I think you have to this is why these things are so important, and you have to compliment this hospital for doing this kind of program, because I think women do need to be empowered and to be their strongest advocate. And you should, first of all, if your doctor isn't listening to you, find another doctor. There's great physicians who really do focus on women and want to take care of women. So if they're not listening to you, then they're not the right person for you. They might be the right person for your husband, but they might not be the right person for you. I would make it clear, first of all, for just the basic risk assessment, blood pressure should be checked. Your cholesterol should be checked. So that does require blood work. They need to know if you're diabetic or not in order to do that basic risk assessment. The other stuff they should be asking about. It's our failure that sometimes we haven't educated physicians entirely in the best way. We know that we're still catching up on teaching our our medical students, our residents, our fellows to know what they need to be asking women specifically. But I would actually specifically say, I don't know what's going on. I'm having chest pain or chest pressure or whatever the symptom is, and I want it evaluated. I want to know if I'm at risk for a heart attack, and I also want to know what's going on.
Complain more. And there's actually evidence to show that patients, men or women, who complain more get better care. They do. So complain more. So that's why we're doing this program. We want people to know what the issues are, and then talk to your doctors about it. And if they're not listening, complain more, and get the care that you deserve. Women don't. We have a question from way back.
Okay, so is it not a connection between sleep apnea and high blood pressure and heart disease? And my second question would be, how aware are our doctors in regard to that?
So there is definitely a connection between sleep apnea and heart disease on many levels. Hypertension is one of them, and specifically people who we have trouble controlling hypertension. Sometimes the reason is because they do have underlying sleep apnea. And so it is something that we need to be asking about, especially if someone has symptoms that are suggestive of sleep apnea. It's something very easy for us to diagnose, but with a sleep study, and actually relatively easier and easier now to treat, because I know a lot of people, when they think about sleep apnea, they think about this big face mask on them. They've gotten smaller. There's different things that they might do for you to make sure that the fit is perfect for you. I do think that there is some level of discrepancy in terms of what we teach our physicians. As I said, that we have to make sure everyone leaves equipped to know these differences, to know that sleep apnea is a risk factor, and for people to know about just the sex-specific stuff that we talked about. I was just interviewed before I came in here by the video that they make when you get to come to Methodist, and they were just asking, where is the biggest gap? And I do think that some medical schools are doing fantastic at teaching sex differences of all diseases, but other schools are not. And even where I came from, where I am right now, they told me that if I wanted to teach about sex differences in heart disease, that should be a special interest group, that was a voluntary thing, that they weren't going to have it part of the core curriculum. And I just was flabbergasted that was their viewpoint, because I know heart disease, but I'm assuming for other diseases, sex differences are important. So we have a long way to go in our education to not be fixed in the old ways and to modernize to what we're learning now.
We have more questions up on the board there. I realize that now we're supposed to be having time for a break, but why don't we just keep going into the discussion, because there's still a lot of interest. And if you need to take a bio break or you want to get some coffee, please go ahead. But let's keep talking for a few more minutes.
Okay.
And why don't you start? Actually, there was one here at the bottom. That was actually the first one. How to distinguish a heart attack from a panic attack.
Probably the hardest thing in the world, but I will always tell people that it's not a panic attack until proven otherwise. We don't suffer, we all have anxiety and stress, and that is my pet peeve when women are labeled as, that it's amazing. In the emergency room, a man will say, I feel my heart racing and, I don't know what's wrong. They get an EKG. Nobody asks them anything about what's going on in their personal life. For a woman, they're like, are you under stress? Like so we're all under stress, right? I mean, that is life in this world. And that stress may be causing you to have a heart attack. So I think that labeling, even when patients say that to me, they almost are embarrassed that they're in my office. They're like, this may be all anxiety and I apologize. I'm like, it's only anxiety till we say that there's nothing else going on. So please get that out of your mind, because I've had patients who were told it was anxiety, this heart racing in their chest. Turned out they were having something called atrial fibrillation, and it took us no time. Once we did an EKG, there was the atrial fibrillation. That put them at a higher risk of stroke. If we hadn't found that, who knows what could have happened to them. So just don't, we have this tendency as women to apologize too, as if we're bothering people, and we really aren't.
Yeah, please speak to this craze about the ketogenic diet.
Yeah, and you heard this from even the last speaker. That physician was telling you that there's, the best diet out there, and it's not a diet, it's a lifestyle. Like when we say diet, I think the best thing is to follow a Mediterranean lifestyle. And that means a very colorful diet. By colorful, I mean lots of fruits and vegetables. If you can try to get your protein sources either from fish twice a week and plant-based maybe some of the other times. But if you're going to eat meat, limit. I know I'm in Texas, I'll probably get thrown out of here, but you're not supposed to. Don't eat red meats too often. Moderation is key. But try to substitute, even if once a week. You might say, I don't eat, tofu or vegetarian-based things. Try once a week. Just try to make your protein source come from plants just once a week. There's so many cool things out there. I'm a vegetarian, so I can say this, but they, at Whole Foods, they sell these burgers that look like burgers. I mean, honestly, if I didn't see the packaging, I would have thought it was meat. They're made of pea protein. You barbecue them. I've had meat eaters, including my dog, who thinks they're like the best thing. He thinks I'm eating a burger on him, but he ends up eating half of it. But I'm telling you, there's so many new things out there. Even if you're anti-soy or don't want to have a lot of soy, there's so many choices out there nowadays that can really change your diet. But Mediterranean diet is probably the best. If you have high blood pressure, you'll hear a lot about the DASH diet. It really is the Mediterranean diet with a little bit of lowering of the salt consumption. So it's focused on balancing, having diet that's richer in potassium. That comes from a lot of the green leafy stuff. Potassium's good for you, sodium's bad for you, or salt is bad for you. That's what's raising your blood pressure. That's the only difference that I make specific for somebody with high blood pressure. But all these other diets, you'll see They keep doing studies comparing head to head, low carb, low, high fat. It's really about calories, moderation, and lifestyle. And so eating healthy, feeling full, but also not, I think sugar is a bigger enemy for us. I would say that for women tends to help them gain weight. And it's causing issues why we're having such a diabetes craze and central obesity. That tends to be a sugar problem. I think if we could eliminate sugar and the simple carbs from our life, we probably do a lot more for heart disease. And there's more and more evidence that might be the bigger culprit in our diet. So think about that when you're eating, because there's so many things that add sugar, even breads. If you're not making the bread, you don't know that they didn't add sugar and salt to it. Making things yourself, you know what you add to it, but there's a lot of hidden things in our food and the food preparation. And that's why I think going back to simple things, it's almost like looking at what we're eating and making sure we're not eating on the go as much. I think those are the things that we can do that are simple.
There are many large clinical trials to support what Dr. Gulati just told you, that a Mediterranean diet is the best diet for your heart. And among those was the DASH study you mentioned, and also the Diet Heart Lyon study,
Yes.
which showed that the Mediterranean diet is actually superior to the American Heart Association low-fat diet that was recommended at the time. But now our approach is more toward, mine approach as well, is more of the Mediterranean diet. There's a question right here.
Good morning. I'm a community health worker, and I do a lot of outreach in the community, especially with women's health and prenatal care, getting the young women to access prenatal care. And oftentimes I come across young ladies after they had their baby. I always ask them, how was the delivery? And then when I start hearing about the preeclampsia and HELLP syndrome and a lot of different things that happen with their blood pressure, I did find a flyer that talks about the different risks of heart disease, and they were just flabbergasted. And I just wanted to know, what are some strategies on getting these young women to start talking to their doctors about their risk for heart disease when they become, menopausal, premenopausal, when they get older, because, they're young and they don't think it's anything wrong with their heart, and that there's no relationship between the adverse pregnancy outcome and heart disease.
So we're working a lot. Actually, it's interesting what's happening in our cardiology community is that we're realizing that women tend to say that their primary care physician is actually an obstetrician gynecologist. A lot of women, that's who they think is their PCP. That's who they go to for their lifetime. So we're actually partnering now. The American College of Cardiology is partnering with the American College of Obstetrics and Gynecology. And this is creating a really wonderful relationship, because I think they know what's happening, and they're realizing that they are the primary caregiver and how can they help them. We also are just finishing up a paper called Redefining the Postpartum Visit. So classically, the 6-week postpartum visit, it's based on no science, but nonetheless, that's what it's always been. But we are trying to redefine it. What should be addressed in that appointment? The interesting thing about women may not, there's things that we'll forget, right? But the one thing women don't forget, and there's a lot of studies on this recall data, anything related to pregnancy, they know the weight of their child, they know what week they had it, in terms of gestational age, they know the length of the baby if you care for that information, but they also know all the complications that they had during pregnancy. There's an excellent recall about things related to their pregnancy. There's no reason we shouldn't be asking that. The question really becomes who should be asking that. And now with the American College of Obstetrics and Gynecology, we are working with them because we're all saying the same thing. They're the ones taking care of the women. They're the ones that will identify the women at risk. They may not know what to do for them to treat the risk, but they will know who needs us, whether it's an internist, whether it's a cardiologist, what is the next step for them. So I've actually planted myself in my gynecology clinic, so the postpartum, to make it easy for women, I literally will see them while they're there, because the other thing that you may not be aware of is that women are just too busy after they have a baby. So only 30% of women actually make it to their 6-week postpartum visit, let alone if you tell them to go see yet another doctor. They're too busy. And so now we're trying to figure out how can we make it simple, how can we address the risk factors, and how can we do it almost at a one-stop shopping, if you will. We don't have a perfect answer on all of that, but I hope that you'll continue to look for stuff, especially given your role in the community, and looking for, between the American College of Obstetrics and Gynecology and the American College of Cardiology, we're creating literature, webinars, things that are really easily accessible for people to use at home and also for physicians to download, but it's also for patients.
We're going to take a 5-minute break in just a minute, but before you leave, I want to give you some resounding applause for a spectacular...